what is labor and what is delivery. Often these two terms are used interchangeably, but they are not synonymous. What is labor? Labor, childbirth or parturition is the series of events takes place in the female genital tract in an effort to expel the viable products of pregnancy from the uterus through the vagina into the outer world. All these points are important. Labor means the series of events which takes place in the female genitalia in an effort to expel viable fetus. This is very important. Viable fetus from the womb through the vagina, not through abdomen, through the vagina into the outer world. This is what is called labor. But delivery, labor may be preterm. It is called preterm when the process happens before 37 completed weeks. It may be term. Term means between 37 and 41 completed weeks. And it may be post-term when it goes beyond 42 weeks or 294 days. All these calculations are made from LMP. We call it preterm, term or post-term. These are calculated from the LMP. Next, delivery. Delivery is expulsion or extraction of the viable products of conception either by vagina or through the abdomen. The difference is here, expulsion or extraction of viable fetus either vaginally or abdominally. When it is extracted via abdomen, it is cesarean section, and vaginally expulsion and extraction difference. What is the difference between in the previous definition of labor, we have used the term expulsion and here extraction. Vaginal delivery, it may be with forceps delivery, that is also extraction of the vaginal baby. So this is the difference between labor and delivery. Next, what is normal labor? What is normal labor or eutosia? Normal labor, to qualify labor as normal, it should fulfill these criteria. Number one, the onset will be spontaneous. That is, the labor pain will start automatically. We will neither interfere nor induce. So it should be number one, onset should be spontaneous. Number two, it will be between the completed weeks 37 to 41 completed weeks, and that means labor will start at term. Preterm or post-term are not normal labor. Tale onset should be spontaneous, it should start at term, it should neither be complicated nor unduly delayed. When we will go through the stages of labor, we will discuss in detail. So the other point is, it should not be delayed or unduly complicated. Number four, it will terminate, the process of labor will terminate naturally with little or no aid. With little or no aid. What is little aid? Episiotomy is an operation. Episiotomy is included in normal delivery. So this much aid we can do, and finally the outcome after the completion of the birth, both the mother and the baby should be in good health. So here you see, normal labor is a retrospective diagnosis. Until and unless labor is completed, you cannot call it whether it is normal or abnormal. Often patients ask at the near term, sir, shall I have normal delivery? So we can predict, but we cannot with confirmation call it a normal delivery, that yes, you will have normal delivery, because normal delivery is a retrospective diagnosis. After delivery, all these points should be considered if that particular labor fulfills all these criteria, then and then only we can say this is normal delivery. Okay. Next, before onset of labor, a phase comes which is called pre-labor. Pre-labor is a time period from few days to few weeks. Few days in cases of multigravida and few weeks in cases of primigravida, during which the following changes takes place. These changes are namely, number one, lightening. Lightening means patient feels a sense of relief. Particularly in primigravida, the head enters the pelvis, that is the head engages after 36 weeks. When the head descends down inside the pelvis, so the pressure symptom caused by the distended abdomen are relieved to some extent. So the patient feels a sense of relaxation, a sense of lightening, as if the abdomen has become lighter. This is what is called lightening. As because the head enters the pelvic cavity, the vertical height of uterus is diminished, the compression over the diaphragm is reduced. So the patient patient suffering in late pregnancy from shortness of breath, breathlessness, these are reduced. This is what is called lightening. Number two, ripening of cervix. Before onset of labor, you know, in early part of the pregnancy, length of cervix is 3 to 4 centimeter. So, near term, the cervix ripes due to some chemical changes we will discuss later on. So, here ripening of cervix means that it is shortened, it becomes softer and it is dilatable, or at least it admits one finger. Normally in pregnancy, the cervical canal remains closed. So, what is a ripe cervix? A ripe cervix is whose length is less than 1.5, but 3 to 4 centimeter to diminish to 1.5. যখন fully effaced হয়ে যেতে পারে, কিন্তু রাইট সার্ভিক্স এটা Bishop's score আছে. When we will discuss induction, we will discuss in detail. So, what is a ripe cervix? A ripe cervix is the cervix is shortened, it has become softer, and it is the cervical opening, the cervical canal is opened. It easily admits one finger and it is dilatable. You can stretch it. It is so soft that you can stretch it. So, that is what is ripening of cervix. Number 3, false labor pain. False labor pain, what it is? You know, throughout the pregnancy, as fetus is a foreign body, uterus always tries to expel it. Throughout pregnancy, this incoordinate and irregular uterine actions, which are called Braxton-Hicks contraction, this is a sign of pregnancy. A Braxton-Hicks contractions, as the pregnancy goes near term, they become stronger, more frequent. So, it causes some pain. It causes some pain. Normally, Braxton-Hicks contractions do not produce pain. False labor pain, it is mostly seen in primigravida. Multigravida usually do not suffer from false labor pain. Cause exactly not known. Most probably, if the head engages, pressure on the nerve ganglions probably cause this pain. Number 4, so. What is so? So, you know, in a pregnant uterus, the cervical canal remains closed by a mucus plug, which is called cervical operculum. This mucus plug, when cervix is taken up and dilated, it dislodges. This mucus plug dislodges, and as cervix is dilated, the membrane in the lower pole got separated from the cervix. So, there is some amount of bleeding from torn capillaries. So, that bleeding with this mucus plug constitutes the show. Show means, so to you know, so is showing something. It shows that labor is inevitable. When the show is also more seen in primary gravida. When patient, what patient will say, sir, একটু আমার একটু সাদা স্রাব ব্লাড স্টেইন এরকম পিঙ্কিশ ব্লাড স্টেইন একটা হোয়াইট ডিসচার্জ হঠাৎ হলো, তো ইট heralds onset of labor. Okay, true and false labor. এই যে একটু আগে আমি বলছিলাম যে onset of true labor pain, how will we decide whether the patient is actually in labor or not? অর্থাৎ she is having contraction, she is having pain, but you will have to qualify, you have to diagnose that is it really true labor pain or it is false or spurious pain. So what are the criteria of true labor pain? Number one, contractions should be at regular intervals. Braxtonics, what I said, Braxtonics contractions are irregular and incoordinate, but onset of true labor pain, the contractions will be at regular frequency with increased frequency, duration and frequency, duration and tension. অর্থাৎ এটা intensity, অর্থাৎ যত সময় যাবে it will be more frequent, contraction will be more in intensity and duration of the contraction will be much more. Normally normal, আচ্ছা এটা পরে আছে আসবো আমি। Pain, nature of pain. In true labor pain, pain starts in the back, then it comes in the front of the abdominal cavity, anterior abdomen, and radiates through the thighs. But in false labor pain, there is a dull aching pain confined to anterior abdominal wall. So this is the difference, the nature of pain, true labor and false labor. Number three, in true labor, the pain will coincide with onset of contraction. You will feel the contraction. If you put your hand over patient's abdomen, you can feel the contraction, and the amount of pain will directly depend on the force of contraction. But in Braxtonics, but in false labor pain, pain is not related to uterine contraction. Number four, so discussed earlier, true labor, in true labor pain there will be so because there is taking up of the cervix and dilatation of the cervical opening, so the mucus plug will dislodge with some bleeding. Walking, if the patient walks, true labor pain will increase in walking, but false labor pain will decrease. Associated findings, if you do vaginal examination, you will see the cervix is effaced or there is some amount of dilation of the cervical canal. Unless you do a pervaginal examination, you cannot diagnose rightly that whether she is in labor or not, whether she will be admitted or not. In emergency, you have to perform a vaginal examination to note whether cervix is taken up or dilated. If you see on vaginal examination cervix is closed or os is closed, we say it is a false labor pain. We give her some sedation or enema. Next point is that enema and sedation. Enema and sedation usually cure false pain. False pain, if she is suffering from false pain, if you give her an enema and sedation, the pain will reduce. But true pain, true labor pain will increase. Enema, what happens? In enema, there is motility of the gut is increased, it reflexly stimulates the uterus. So in true labor pain, the contraction will increase after giving enema. Now comes physiology of labor. Physiological changes that must happen before onset of labor to have a fruitful labor. Number one, age. What is the ideal age of for first pregnancy? The ideal age for first pregnancy is between 18 to 23. It has been noted that if the girl delivers by this age, she will have least complications. Early teenagers, that is before 18 or after 30, particularly primary, they are considered as high risk pregnancy. Or in cases of multi, above 30. So this definition needs some change. Nowadays, girls marry at the age of 30 and they are, when we were students, elderly primary gravida was defined as any primary gravida above 25 years of age. But now it is 30. Elderly primary now defined as over 30. Next, uterine contraction. Physiology of uterine contraction. Uterus is a large organ. In pregnancy, it is a very large organ. So, where from the contraction starts? Uterus develops from two Mullerian ducts, two equal halves. A normal uterus develops from two equal halves. So, uterine pacemaker lies at the uterotubal junction, at the corner of the uterus, where the tube, fallopian tube enters the fundus, body of the uterus. So, that is the uterotubal junction where there is the pacemaker of uterus. Contraction starts from there and it rapidly progresses downwards throughout the uterus in about 15 seconds. Both the pacemakers situated on both cornu are active, but usually the right one takes advantage. That is, the right pacemaker, right sided pacemaker is more active than left side. Okay, uterine pacemaker. Number 2, fundal dominance. What is fundal dominance? If you look at the structure of uterus, uterus is made up of 3 layers of muscles. Inner circular muscle, middle oblique and zigzag course. This is the most thicker part of the muscle layer, and outer longitudinal. So, contents of muscles is more in the upper part of the uterus, body of the uterus. So, there are few muscles in the cervix. Cervix contains only 10 to 15% muscle fibers. Rest of the cervix is composed by collagen fibers like collagen, elastin, etc., and other chemicals, extracellular chemicals. So, number of fibers is maximum in the fundal area, in the body of the uterus. So, when contraction starts from fundus, lower part of the body and cervix, as there is less muscle fiber, so it is the passive segment. Upper part, fundus becomes dominant part. Contraction initiates in fundus, it propagates it pushes the baby downwards, and the lower part, that is lower pole, it is a passive pole. It just stretches and it forms a receptacle to accommodate the baby, the fetus. Upper and lower segment, upper segment the active segment, the fundal area, and lower segment the passive segment, just I told you. Then physiological retraction ring. As the contraction goes on and goes on, uterine muscle is unique in one characteristic. No other muscle in the body has the capability of retraction. What is retraction? When a muscle, we all know, when a muscle contracts, it becomes shorter and thicker, and when it relaxes, it comes to its original position. But uterine muscles has the unique capacity of retraction. Retraction means when it contracts, it becomes shorter. When it relaxes, it doesn't come back to its original size. There is some amount of permanent shortening. If this would not have been happened, baby would not have been extracted. Like other muscles, if it contracts and relaxes and comes back to its original position, the baby should have in the same position. So, because of this character, retraction means permanent shortening in the length of the muscle. After contraction, it will never regain its pre-contraction or pre-contraction length, it will be permanently shortened. So this is the peculiar character of uterine muscle. So as contraction goes on, the upper part, the active part muscle is becoming shorter, so it will be thickened. The upper part will be more and more thickened, and lower part is, passive part is stretching, so it will be thinner and thinner. Upper part will be thicker and thicker, and lower pole will be thinner and thinner. So at the junction of the upper pole and lower pole, there inside the uterus, you can feel a ridge, irregular ridge. That is what is called physiological retraction ring. Orthat, you can demarcate that this one is the upper part, this one is the lower part. A ring is seen in the, it is not seen from outside, it is inside the uterus. But in obstructed labor, when this process goes on and goes on, that means upper segment always trying to expel the baby, contraction goes on, lower segment gradually becomes thinner for over a long time, then this ridge could be seen from outside. A depression, irregular depression is seen, that is what is called pathological retraction ring or Bandel's ring. Pathological retraction ring seen only in obstructed labor. Obstructed labor, so physiological retraction ring and pathological retraction ring. Number 3, tonus, resting tone of the uterus. Normally in pregnant condition, the tone or the pressure of the intrauterine of the amniotic fluid is 4 to 6 millimeter of mercury. Normal resting tone. When labor starts, uterus contracts, intraamniotic pressure will go up. In first stage, it may go up to 40 to 60 millimeter of mercury. And after the contraction passes over, it will have relaxation phase, then it will come down to near about 8 to 10 millimeter of mercury. In second stage, if the intraamniotic pressure goes up to 80 to 100 millimeter of mercury. These are important because if there is no relaxation in between contraction, that is, if uterus goes in a state of hypercontraction, hyperstimulation, so what will happen? As the uterus will contract, as the blood supply to the placenta goes through the muscle layer, when uterus contracts, the blood supply will be hampered, the blood vessels will be strictured, blood supply would be hampered. A normal fetus is capable of withstanding this short period of hypoxia, but a already hypoxiated baby will not withstand this stress of labor. So a tonus is very important. Tonus, if it is more than average, it will cause fetal hypoxia. Duration and frequency, these are measured in frequency is measured in time span of 10 minutes. That is, how many contractions are there in 10 minutes. Normally in established labor, it comes in every 1.5 to 2 seconds. That is 3 to 5 contractions per 10 minutes. Duration, frequency of contraction, 3 to 5 contractions every 10 minutes in established labor. It is the frequency of contraction. Duration, in the first stage I said 40 to 50 seconds, in the second stage 40 to 60 seconds, in the second stage it may go up to 70 seconds, more than 1 minute. False labor pain, the contraction duration will never be more than 30 seconds. Next, Montevideo unit. Montevideo unit is the clinical measurement of this intrauterine tension. Montevideo is the name of a place in Uruguay. Barcia and Alvarez, they find out this Montevideo units. Montevideo karun naam noy. Montevideo is the name of the place where from the paper was published. So, what it calculates that in a 10-minute period, number of contractions, suppose a patient had 3 contractions in a 10-minute period. In these 10 minutes, the highest intrauterine pressure and resting intrauterine pressure are measured. By deducting the resting pressure from the highest pressure, the value of all the contractions in that 10 period are added. Understand kya? Suppose there are 3 contractions in 10 minutes. In first contraction, the resting pressure is 10. At the height of contraction, the pressure is 80. So, if you deduce, it will be 70. Similarly, in second contraction, it became 60 or 70. In third contraction, it became 80. So, adding these 3 figures, 60, 70 and 80, it comes down to 210. Adding these 3 figures, we get Montevideo units. Usually, by this, we can diagnose true labor. If the Montevideo units are more than 150, above 100, it is true labor. It may go up to, at the peak, it may up to be 200. So, Montevideo units হচ্ছে pressure difference at the peak and resting pressure by adding the pressure difference of different contractions in a 10-minute period gives the Montevideo units. If it is more than 100, we say patient is in true labor, and if it is less than that, then the patient is in false labor. Number 4, retraction. So, already discussed what is retraction. Then lower segment formation, lower passive segment is lower segment. Where from lower segment comes? Lower segment formation actually starts around 16 weeks, 14 to 16 weeks of pregnancy. It goes on. Lower segment develops from isthmus of the cervix. Isthmus is the portion of uterus between the body and cervix. In non-pregnant condition, the length of isthmus is only 0.5 centimeter, half centimeter. It is bounded above by anatomical os and below by physiological os, by histological os, above by anatomical os. So, this 0.5 centimeter area, when it is fully developed, lower segment, it becomes 3 to 4 inches, 7.5 to 10 centimeter. How will you identify? After opening the abdominal cavity, look at the uterus, how will you, what we do? তোমাদের সিজার পড়িয়েছি কিনা জানি না, lower segment cesarean section. So what is, how will you identify which one is the lower segment, where I am putting my incision, whether I am putting my incision on upper segment or lower segment? How will you identify? The identification mark is that it is just above the bladder, and over the area of lower segment, the peritoneum is loosely attached. You can easily separate the peritoneum, but above that, in fundus, peritoneum is attached inseparably. You cannot separate the fundus. You cannot separate the peritoneum from the body of the uterus. So, clinically, we will identify lower segment by noting that the peritoneum is loosely attached. Before cesarean section, we first cut the peritoneum because it is loosely attached. We cut it, we push down the bladder, then we make the incision. Incision is always made. Incision is never given. We give incision, is wrong, never say. Incision is made. We make an incision, then descent. Descent is a continuous procedure throughout the labor. Descent is going on. Placental separation. Placental separation, we will come into it in the stages of labor, third stage of labor. Preventing PPH, these are management of third stage. Number, pain also discussed later. Mechanism of onset of labor. Who decide or how it is decided that this is the right time to start labor? No single theory Actually, till date, we do not exactly know, what exactly is the cause of onset of labor. Many theories are put forward. None of these explain all cases of normal delivery. The most accepted and common theories put forward are: number one, progesterone withdrawal. Progesterone, the hormone progesterone is called progesterone because it promotes gestation. Where from the name came progesterone? It promotes gestation. That means progesterone is a hormone which maintains pregnancy. You all know, in cases of history of abortion, by premature labor, we give progesterone to continue the pregnancy. So, if there is progesterone withdrawal, actual or functional, if there is progesterone withdrawal, uterine irritability increases and that produces uterine contraction. So, what happens? Actually, it is seen that near term progesterone withdrawal occurs by: number one, progesterone synthesis is reduced to some extent. Number two, progesterone is destroyed locally, progesterone receptor expression is diminished. So, all these factors are important. Number one, synthesis of progesterone is reduced, is diminished. There is local destruction of progesterone by enzymatic action, and third, the expression of progesterone receptors are diminished, or that progesterone receptors are there but they are not functioning. All these three factors leads to functional withdrawal of progesterone, and when progesterone is reduced, the ratio of estrogen progesterone ratio is altered. Estrogen progesterone ratio, if it is altered, it increases myometrial excitability. Result how? By producing contractile proteins, actin, myosin, by promoting local synthesis of prostaglandins, and by inducing more oxytocin receptor. So, progesterone withdrawal is a cause of onset of labor, but you cannot explain all things because it happens near term. So, how will you explain a premature labor? Uterine stretching of uterus. Stretching, as pregnancy grows, uterus is gradually stretched, and at a certain time, when that stretch is maximum, labor pain starts. It is at least proven by how can you prove that stretch can cause labor? In multiple pregnancy or in pregnancy with polyhydramnios, uterus is overstretched. There, premature labor, that is preterm labor, is almost a rule in multiple pregnancy and polyhydramnios. So, stretch is another factor to initiate onset of labor. Number three, this one is the most accepted theory till date: fetal hormonal cascade, endocrine cascade. What happens? Near term, fetal hypothalamus and placenta produce a large number of CRH, corticotrophin releasing hormone. This corticotrophin releasing hormone acts on fetal pituitary, produce more ACTH. This ACTH will stimulate fetal adrenal to produce excess amount of cortisol and DHES, dehydroepiandrosterone sulfate. These two hormones, excess cortisol prevents excess synthesis of progesterone, and DHES, from DHES placenta produce large amount of estriol. So, here the estrogen progesterone ratio is altered. What happens? This high levels of progesterone. So, actually the rising level of CRH near term, it sets on the physiological clock to trigger the onset of labor. So, this is the most accepted theory for initiation of onset of labor. So, what happens? It acts through fetal hypothalamus, pituitary, adrenal Placental. Placenta is an incomplete endocrine organ. Placenta produces hormones, various hormones, but they depend on fetal adrenal for their precursors. Placenta is not a complete endocrine organ. It is an incomplete endocrine organ. So it depends. That's why Dick Fellows is, when you will go through fetal status but fetal condition in abdomen, fetoplacental unit, Dick Fellows' theory, it indicates the condition of the fetus, because the estriol is produced by placenta, but its precursor comes from fetal adrenal. Fetal lung surfactants. As we all know, as the fetal matures, the pneumocytes inside the lungs, fetus does not respire inside the abdomen, but the lung has to prepare after delivery. So chemicals are produced by pneumocytes, which are called phospholipids. So they are called surfactants. Say surfactant proteins, glycoproteins, surfactant proteins produced by the fetal lung comes into amniotic fluid, and it initiates prostaglandin synthesis. At the onset of labor, the number of oxytocin receptors are increased in uterus. So oxytocin stimulates contraction. Actually, oxytocin is required for completion of labor, but not for initiation. Oxytocin does not initiate labor so effectively. Actually, it helps in completion in the later part of the labor, because it is seen in hypophysiectomized animal. Hypophysiectomized means pituitary is removed. Even after removal of the pituitary, the labor starts on its own. So oxytocin is not necessary for initiation of labor, but it is necessary for completion of labor. And number 4, relaxin. Relaxin is a hormone which relaxes the pelvic structure, namely muscles, joints, etc., and helps in labor. Number 5, prostaglandins. These are crucial, and it is the final common pathway. Whatever be the process, ultimate result is local prostaglandin synthesis. Prostaglandin synthesis. চেঞ্জ করে দিচ্ছি, বেশি চলে গেছে। Prostaglandin synthesis. So this is the final common pathway. Whatever be the mode, whatever be the theory behind initiation of labor, that will ultimately produce excess prostaglandin. Be it your inflammation, infection, cervical stripping, amniotomy, local prostaglandin. If you give local prostaglandin, labor pain will start. So prostaglandin is the final common pathway and most crucial. Stages of labor. Stages of labor. Labor is divided into 3 stages. First stage is from onset of true labor pain to full dilation of the cervix. First stage, from onset of true labor pain to complete full dilation of the cervix. It takes about 10 to 12 hours in primary and 6 to 8 hours in multigravida. Second stage of labor, from full dilation of the cervix to expulsion of the baby. It is second stage. Normally it is 2 hours in primary gravida and half to 1 hour in multigravida. And third stage, the stage of expulsion, separation and expulsion of placenta. The third stage is after birth of the baby, to expulsion of the fetus, expulsion of the placenta and umbilical cord. This is third stage. These are the 3 stages. It lasts for, in both cases, primary and multi, 15 minutes maximum. If placenta is not separated within 30 minutes, it is called retained placenta. That if placenta does not separate by 30 minutes of its own, it will not separate of its own again. So you have to take some procedure. Number 4, fourth stage. Fourth stage is the first hour after delivery, after completion of delivery. That means after delivery of the placenta. In some books it is written 2 hours, in some books it is 1 hour, whatever it is. The first hour after delivery, it is considered fourth stage because most of the dreaded complications of pregnancy, the pregnancy which was normal throughout first stage, second stage, etc., suddenly become complicated because of PPH, because of acute inversion. So third stage, fourth stage is very important. So you do not shift the patient after delivery immediately to the labor ward. Patient should be kept in the observation room for at least 1 hour and will be checked regularly. After 1 hour, you can send her to ward. So this is the importance of fourth stage of labor. Events in the first stage is up to full dilatation. So what are the events? Dilatation, effacement. Effacement I have already discussed. Dilatation, how do we qualify dilatation? 1 finger, 2 finger, 3 finger, 4 finger. 1 finger is equal to 1.5 centimeter. When we examine patient, we introduce 1 finger or 2 finger. 4 finger dilation doesn't mean we introduce 4 fingers. We introduce 2 fingers, and by judging the gap between the 2 fingers, this is 3 finger, this is 4 finger or full dilatation. We never introduce more than 2 fingers. 4 finger dilatation, but full dilatation doesn't means that cervix is fully dilated. You do not palpate any cervical rim. Okay, that is full dilatation. Full dilatation is equivalent to 10 centimeter dilatation. Uterine contraction, retraction and polarity already discussed. Contraction and retraction we already discussed. Polarity, what is polarity? Polarity is when upper segment contracts, lower segment relaxes. This is what is called polarity of uterus. Number 3, formation of lower segment explained. Fetal axial pressure. What happens in normal pregnancy? The position of the fetus is a position of complete flexor. All the joints of the body are in flexed position. Because why? Because it takes minimum space. The fetus remains in a phase of complete flexor. All joints are in flexed condition. It requires minimum place. So what happens in labor pain when the circular fibers contracts? This position, complete flexion, fetus is to some extent straightened. Straightened হয়ে যাচ্ছে, ভাঁজ হয়েছিল, সার্কুলার মাসলগুলো কন্ট্রাক্ট, যদি অনলি যা লংগিচুলার ফাইবারস কন্ট্রাক্ট তাহলে তো আরো ফ্লেক্সড হতো, কিন্তু এই সার্কুলার, বিকজ অফ দ্য কন্ট্রাকশন অফ দ্য সার্কুলার ফাইবারস, the baby is to some extent straightened. So the pressure originated in the fundus is transmitted through the fetus also. The fetus axial pressure. Disaturgo, that is downward thrust from above and taking up of the cervix, that is pulling from below. This causes full dilatation. One point is not mentioned here: synchronization of contraction. Two pacemakers should act synchronization. Otherwise, what will happen? If the contraction are not synchronized, there will be incoordinate contraction. As a result, patient will feel pain, but there will be no progress of labor. Okay, that is what is called incoordinate contraction. Second stage is divided into 2 phases: phase of propulsion, when the head comes down, and phase of expulsion, when the head is born. What are the things happen here? One term comes down: bearing down. What is bearing down? In labor, you have to consider three things. Number 1, power. Number 2, passage. Number 3, passenger. Orthat, to expel the baby out, you should the baby of average size, that is the passenger should be of optimum size. Power, contraction of the uterus, and bearing down effect, the contraction of the abdominal muscles. I will come to it later. And number 3, passage, that is pelvic uterovaginal canal. The pelvic cavity should be of optimum size. These 3, when these 3 are optimal, then and then only normal delivery is possible. So what is bearing down? Bearing down is the contraction of the voluntary muscles. In first stage, the power is only contraction of the uterus, but in second stage, when the baby comes down, the patient initially starts bearing down. Bearing down ki what she does? She inhales a big inspiration, fixes the diaphragm and contracts the abdominal muscles. This pushes the baby downwards. So this is what is called bearing down. At the beginning, it is voluntary. Patient starts it, but after some time, in full progress, it becomes involuntary. So bearing down pain is the involuntary contraction of voluntary muscles. When labor is fully established, the contractions become, though the muscles involved are voluntary, but the contraction of the muscles is involuntary in the later part of the labor. Vaginal examination, what we do? Vaginal examination, we see the cervical effacement, dilatation, station of the vagina, presenting part, rotation, whether rotation is complete or not, and finally assessment of the pelvis. আমরা pelvis assessment করে দিই যেটা ঠিক হবে কিনা. Crowning, what is crowning? When the maximum transverse diameter of the presenting part crosses the diameter pelvic inlet, outlet, that is called crowning. How will you know that it is crowned? Head is crowned. How will you know? যে তুমি তার মাপছো না, বসে নেই ওখানে, দেখছো কিভাবে হচ্ছে. How will you know that the head is crowned? It will not recede in between contraction. Normally, if you look at the normal delivery, when uterus contracts, when the patient bears down, the head is coming out, and when contraction goes up, it again recedes. This continues for some time. At one time, it will come when the head will not recede during relaxation phase, or that head is fixed. It will not recede during relaxation. That is what is called crowning. Crowning means head will not recede in between contraction. Next, delivery of the fetus. Delivery of the fetus is never done at the height of contraction. It should be done in between contraction. At the height of contraction, sudden delivery may cause tentorial tear, intraventricular hemorrhage. This may happen. So delivery of head is very important. It should be delivered in between contractions and asking the patient to bear down. Patient যেটুকু bear down এ force দেবে তাতেই delivery করতে হবে. At the height of contraction, baby head should not be delivered. Third stage of placental separation and expulsion. What happens when in full term pregnancy, the area of placental attachment is almost 20 centimeter of length. What happens just after contraction, just after delivery of the baby, due to retraction? In third stage, retraction is more marked. In first stage, contraction is more marked, retraction is less. Second stage, both are almost same, but in third stage, retraction is much more than contraction. So uterus is retracted. As uterus is retracted, so there is shearing effect. The placenta is detached. Placental attachment area reduced, so placenta is detached. So there are two types of placental separation. One is Schultze method and another is Matthew Duncan's method. Schultze method is central separation, or the central portion of the placenta is separated first. There forms a blood clot, and gradually the placenta comes out like an inverted umbrella. So you will see the fetal surface first, shiny surface. Schultze means shiny, but central. Or marginal separation, placenta separate from a margin. Margin is separation holo, by traction of the separated portion, it pulls out the rest of the placenta. Here you will first see the maternal surface. Dirty Duncan. Duncan method is dirty. Dirty means maternal surface is dirty, placental maternal surface. Superior surface is shiny, glossy. Expulsion of placenta. Expulsion of placenta, we extract the placenta by controlled contraction. Number 3, prevention of hemorrhage. As already discussed, the crisscross fibers through which the blood vessel goes, when they contract, give living ligatures or physiological ligature. একে লিভিং লিগেচার বলা হয়, as if আমরা যখন ব্লাড ভেসেলকে বাঁধি এরা ঠিক সেই রকমই হয়, লিগেচারের মতো কাজ হয়ে যায়। That's why if there is uterine atony, if the uterus does not contract properly, severe hemorrhage occurs. মেকানিজম অফ লেবার ও এসজিডি তেই তোমরা দেখবে, জাস্ট স্টেপগুলো জেনে রাখো। স্টেপগুলো হচ্ছে, হোয়াট ইজ দ্য ডেফিনেশন অফ মেকানিজম? The adaptive and positional changes taken by the head, including the body and trunk of the fetus, for passage throughout the genital canal. এই যে যখন during passage the changes, adaptive and positional changes যেগুলো হচ্ছে সেটাই হচ্ছে মেকানিজম অফ লেবার। প্রথম হচ্ছে এনগেজ, এটা মনে রাখার খুব সুবিধা, এড ফায়ার, EDFIER. E for engagement, maximum transverse diameter enters the pelvic cavity. Descent is a continuous process throughout labor. Descent occurs. Full flexion, as the head descends down by resistance of the pelvic tissue, pelvic passage, it becomes more and more flexed. যত flex হবে তত lesser diameters will come in relation to different pelvic diameters. So flexion is very important. Number 4, internal rotation. Descent, when the occiput touches the pelvic floor is gutter like. When it touches, it rotates anteriorly. 1/8 circle, anterior rotation. The occiput comes below the symphysis pubis. Then occurs extension. Head is bowed by extension. Then comes external rotation. What is external rotation? The external rotation is restitution. Restitution is what before delivery of the head, due to internal rotation, there is a twist in the neck, 45 degree. When the head is bowed, that obstruction is gone, that twist will untwist. So restitution means correction of internal rotation. The twist occurred in neck, that will be automatically corrected. That is restitution. Then due to rotation of the anterior shoulder comes below the symphysis pubis, there will be another rotation of the head in the same direction of restitution. Then the baby is delivered by lateral flexion. ওকে, এইগুলো থিওরিতে বুঝবে না, যখন ওই ক্লাসে ফিটাস আর এই ধরে পড়ানো হবে তো জাস্ট স্টেপগুলো জেনে রাখো, ওগুলো না দেখালে বুঝতে পারবে না, এগুলো ফালতু এ করে লাভও নেই। লেবার মনিটর আমি 2 মিনিটে বলে দিচ্ছি। এই যে বলছিলাম একটু আগে যে আমরা লেবারটা মনিটর করব, যে whether this baby is capable of bearing the stress of labor। তো কেন মনিটর করতে হয়? aim, what is aim? Our aim is to deliver safely, to have both mother and baby in good health after delivery, and a pleasurable and fulfilling experience for the mother. মা একটা এমন এক্সপিরিয়েন্স নিয়ে গেল, ওরে বাপরে আর জীবনে আমি হাসপাতালে আসবো না, যা কষ্ট হচ্ছে, এটা যেন না হয়। Patient should go home with a pleasurable and fulfilling experience. Monitoring of labor, detailed history, তার প্রেসার, ব্লাড প্রেসার সব এগুলো নেবে। জেনারেল এক্সামিনেশন, অ্যাবডোমিনাল এক্সামিনেশন, ফিটাল আল্ট্রাসাউন্ড কেমন আছে, ভ্যাজিনাল এক্সামিনেশন টু ডায়াগনোস অনসেট অফ লেবার। পেশেন্টকে অ্যাম্বুলেশন, পেশেন্ট জিজ্ঞাসা করে ডাক্তার আমি শুয়ে থাকবো 12 ঘন্টা, একটা পেশেন্ট লেবারের একটা নর্মাল প্রায় 12 ঘন্টা ধরা হয়, 12 ঘন্টা তো শুয়ে থাকা যায় না। পেশেন্ট ক্যান ইজিলি ওয়াক অ্যাট লিস্ট ইন দ্য ফার্স্ট স্টেজ। পজিশন, কোনো ডেফিনিট পজিশন নেই, পেশেন্ট মে টেক দ্য পজিশন সি লাইকস মোস্ট, বাট জাস্ট বিফোর ডেলিভারি we ask to take her dorsal position with left side 15 degree tilt left side. Oh, 10টা বেজে গেছে, 1 মিনিট। Amniotomy, when time comes we will rupture the membrane. Bladder care, often the patient suffers from retention of bladder, you have to catheterize the bladder. Fetal monitoring, clinically we count fetal ultrasound, and if the membrane is ruptured we note the color of the amniotic fluid. Electronic monitoring by fetal scalp stimulation test or continuous cardiotocography, these are done. And finally biochemical method, when membrane is ruptured, whether the fetus is become hypoxic or not, you can assess the pH of the fetal blood sample. pH, if the pH is more than 7.25, this is normal. If it is less than 7.2, it is abnormal. অর্থাৎ অ্যাসিডোসিস হলে কি হবে, পিএইচ কমে যাবে, পিএইচ তার মানে বাচ্চা হাইপক্সিক হচ্ছে। আর blood lactate is more important than pH. If blood lactate is less than 2.8, it is normal. If it is more than 3.08, it is abnormal. Pain. Why pain occurs in labor? Number one, due to uterine contractions produce uterine ischemia, that causes pain. Number two, stretching of peritoneum, stretching of cervix, stretching of perineal structures. All these causes pain.